Okay, welcome to Roasted Academy. Please like and subscribe to our channel, for this shows how much you support us. So today let's discuss the diuretic agents. Okay, the diuretic drugs. So I know you are surprised, like I'm displaying something else, but instead of displaying drugs, right? But I'm displaying this particular thing that is here. This is simply going to be your nephron. This is the functional unit of the kidneys. Okay, this is where the diuretics are going to act. Okay, so this is in the kidneys, and the kidneys, the functional unit of the kidneys is simply going to be the nephron. So for us to understand the diuretics, we have to understand first the nephron. Okay, the parts of the nephron. So let's mention the parts of the nephron first, and then we now go to the diuretics. So whenever I'm mentioning to say the diuretics, these diuretics are acting on this particular part, then you know what I'm talking about. You know the anatomy in that particular case, right? Okay, right. This is how you should also study when you are dealing with the diuretic agents. Okay, so um this is simply going to be your interlobular artery. Okay, we know that the blood supply to the kidneys first is simply going to be the renal arteries. Okay, but we're much interested in pharmacology, right? So we won't dwell much into the blood supply. Or yeah, so let me start from the ascending. Okay, interlobular artery. Then I've got this one here, which is the afferent arterial. Okay, blood being brought. Then we've got the Bowman's capsule. Okay, Bowman's capsule, where um, filtration is going to take place from. Then we've got that one, the glomerulus inside here, a tuft of capillaries that is inside there. That's a glomerulus. Okay, then we've got the afferent arterial. This is the afferent arterial here. Just zoom in like this. Okay, I'm not able to do that. So there's afferent arterial, peritubular capillaries. Then here, these vessels, the vasa recta. Okay, the vasa recta. So what I want to say is that these blood vessels have just been put, or have just allocated just next to these particular um, parts of the nephrons, right? So parts of the nephrons, the Bowman's capsule, proximal convoluted tubule. Okay, there are drugs that can act on this PCT, proximal convoluted tube. Then descending limb loop of Henle. Okay, descending limb of loop of Henle. Then we've got the ascending. Okay, ascending, which is this one, right? Ascending limb of loop of Henle. Then we've got the distal convoluted tube. Then we have the collecting duct. These are the parts of the nephron. Okay, the Bowman's capsule. Let's start again. Bowman's capsule, proximal convoluted tubule, descending limb of loop of Henle, ascending, okay, limb of loop of Henle, distal convoluted tubule, and then in the end, the collecting duct. So what happens is that these particular blood vessels have been put, or just next to these particular parts of the nephron, because there's going to be reabsorption of substances, because the kidneys are simply controlling, okay, are simply controlling, for instance, the amount of ions like sodium. Sodium is reabsorbed, water is reabsorbed, and everything is taking place like that in the nephron, right? So now when we say diuretic agents, you find that they will favor the excretion of fluids. That's the thing. So they'll block certain particular channels and favor the extrusion of fluids. So now let's go to the pharmacology perspective point of view, right? Okay. Okay. So now these are the diuretics. Diuretics are drugs that increase urine output by acting on the kidneys, okay, specifically on the nephron, right, to remove excess sodium and water from the body. These are going to reduce blood volume and are mainly used to treat hypertension, heart failure, edema, and renal disorders. Remember that in heart failure, for instance, right-sided heart failure, that there's simply edema, where there's accumulation of fluid in the interstitial space. So different classes act at different parts of the nephron. So these are the main classes. We got the thiazides and thiazide-like diuretics. Examples like hydrochlorothiazide. Okay, hydrochlorothiazide. You have to know about this one. We also have chlorothiazide, chlorothalidone, okay, indapamide, metalazone. All right. Site of action, distal convoluted tube. That's where it's going to act. Then it's going to inhibit sodium chloride symporter. Sodium chloride symporter. Mainly, we say that it simply inhibits the what? The sodium channels here. So it's not going to allow the reabsorption of sodium. So whenever sodium has not been reabsorbed, then you know that also where sodium is, water is also going to fall. That's about that concept. Okay. Uses first line for hypertension, but this time around, right, we have um, different drugs depending on the setup where you are. Okay, depending on the setup and the treatment guideline. What are they saying in the treatment guideline in terms of uh, which drug is going to be your first line in terms of hypertension and everything like that? Okay, standard treatment guideline. It will actually tell a particular country or a particular area where what drugs they should use as first line. Okay, so this is very subjective. Heart failure, yeah. Side effects, problem of these ones, they cause hypokalemia, okay, low potassium, hyponatremia, hypercalcemia, hyperuricemia, and can trigger gout arthritis, okay, hyperglycemia and dyslipidemias. These are the side effects. For contraindications, let's not give in people with the severe renal failure. Because remember that these drugs are simply going to act on the nephron, and this is someone with renal failure, and you are giving them these particular drugs. They will cause renal toxicity in the end. Allergy to sulfur drugs. All right, okay. So that's about the thiazides, right? They'll act on the distal convoluted tube. And then for loop diuretics, these are going to act on the ascending, okay, limb of loop of Henle. So examples, we've got furosemide, bumetanide, torsemide, methacranic acid. So these are very important drugs for loop diuretics. You have to know about these drugs and you have to know all these examples, right? Furosemide, metamide, torsemide, methacranic acid. What is the mechanism of action? These are going to inhibit the sodium potassium 2 chloride pump. Okay, there's a sodium potassium 2 chloride pump which is located in the ascending limb of loop of Henle. So this one is going to be inhibited. So when this one has been inhibited, meaning that sodium won't be reabsorbed, potassium won't be reabsorbed, chloride also won't be reabsorbed. Okay. Also, as it is inhibiting this particular channel, and as it is inhibiting, as they are inhibiting this particular channel, right? Sodium potassium 2 chloride. It's also inhibiting the reabsorption of calcium and magnesium. So these calcium and magnesium are going to be removed out of the body. Okay, going to be secreted out. Uses pulmonary edema, heart failure, severe hypertension, hypercalcemia, renal failure with the fluid overload. What are the side effects? Okay, the side effects of loop diuretics, very simple. You've seen that these particular ones are causing excretion of potassium. So, as they are causing excretion of potassium, what is happening? They are causing hypokalemia, hyponatremia, because of excretion of sodium as well. So, you find that they are trying to inhibit this particular reabsorption, that they are causing more and more abnormal excretion of these particular ions. So it becomes now a side effect. So hypocalcemia as well. Okay, like I said, it's also causing what? Excretion of magnesia. Magnesia, you also include it. Okay, also have dehydration and hypotension. In which people do we not give? Don't give in people who are dehydrated. Dehydration. Okay, that's about that, right? Someone who is dehydrated, what does it mean? Simply means that they have got less of sodium and less water, right? So you are giving to someone with less water as well as less sodium. That means they are dehydrated, and this is going to be contraindicated, right? So meaning that you are going to worsen the situation of dehydration. Remember that dehydration can cause what? Hypovolemic what? Shock. So you can send someone into shock. That's the problem, right? All right, let's look at the other class of drugs, which is potassium sparing diuretics. These are going to prevent potassium loss. So you've seen the side effects of these other drugs, that they are simply causing hypokalemia. So we want some drugs that when we give, they shouldn't cause excretion of potassium. They should spare potassium. We call them potassium sparing diuretics. So these are simply going to be aldosterone antagonists. Example, spironolactone. Spironolactone is very common in the hospital. Okay, it's a very common drug, this one, in the hospital. It, it's most prescribed, right? We've got eplerenone. Okay, so what is the mechanism? This one, you've seen aldosterone is going to block aldosterone receptors and block reabsorption of sodium. Remember that aldosterone is important for absorption of sodium. Okay, and where sodium is, remember, water follows. Okay, yeah. So how are you going to remember that sodium reabsorption um, is preceded by aldosterone? Okay, just remember that Na. Okay, Na. So A for aldosterone. Then we got sodium for aldosterone. That's about that. Sodium channel blockers like amiloride, trimethoprim, they are also very important drugs. They will block the epithelial sodium channels in the distal tube. Usually combined with thiazides to prevent potassium loss. Okay, hyperkalemia. Carbonic anhydrase inhibitors like acetazolamide, dozolamide. Site of action on the proximal convoluted tube. These inhibit carbonic anhydrase. Okay, carbonic anhydrase. This will reduce hydrogen ion production. Then there is reduced sodium hydrogen exchange, sodium and bicarbonate and water excretion will now be promoted. That's about the carbonic anhydrase. There's simply an enzyme known as carbonic anhydrase, okay, where we have got carbon dioxide combining with water forming carbonic acid. So this is the enzyme that we target, and we block the same particular enzyme. So this enzyme promotes the formation of sodium and bicarbonate, so and absorption of these particular ions. So we don't want them in blood, so we make sure that there is excretion. Side effects, okay, uses glaucoma. Okay, these are mostly used in glaucoma treatment. Side effects: metabolic acidosis, hypokalemia, kidney stones. Don't give to people with liver cirrhosis. We also have osmotic diuretics like mannitol. Mannitol, very important drug, right? Where it acts on the proximal convoluted tubule as well as the descending limb of loop of Henle. Mechanism: filtered but not reabsorbed. Hold water in tubules by osmotic effect. So when we say something is osmotically active, meaning that it draws water to itself. Okay, so these ones you find that they are excreted and through the urine they attract or hold on to fluids like water, right? Uses cerebral edema, okay, acute glaucoma, maintain urine flow in renal failure. Side effects: pulmonary edema, dehydration, electrolyte imbalance. Don't give to people with heart failure, okay. Active cranial bleeding, don't give. So what is our summary? We have got drugs that are acting on proximal tubule like carbonic anhydrase inhibitors, like osmotic diuretics, loop of Henle. We've got loop diuretics, okay. Distal convoluted tubule, we've got thiazides. Collecting duct, we've got potassium sparing diuretics, right? All right, okay. That's all. Prepared and compiled by Dr. Rostud Max Banda, Academic Director from Rostud Academy. Thank you so much for watching. Please, you can leave a comment